Good evening. On behalf of the Robert H. Lurie Comprehensive Cancer Center of Northwestern University, thank you for joining us today. I'm Dr. Bill Gradisher, Professor of Medicine and Director of the Lurie Cancer Center's Maggie Daley Center for Women's Cancer Care. I'll be moderating the program tonight. We're kicking off Breast Cancer Awareness Month this evening with a session on advancing breast cancer health equity in Chicago. This is an incredibly important issue, not only generally, but even more so in COVID times, as we see the disparities in healthcare that can occur. Today, we will be discussing reducing disparities in breast cancer care and achieving health equity in Chicago's African American community. I'm pleased to welcome three outstanding speakers for today's program: Dr. Joy Coleman, Dr. Tiasha Bailey, and Ryan Johnson. Following their talks, we'll have a question and answer session where our audience can ask questions to our panel of experts. Let me introduce Dr. Joy Coleman. She's a board-certified radiation oncologist at Northwestern Medicine in Lake Forest. She received her medical degree at the University of Michigan and did her postgraduate training at the University of Cincinnati and the University of California, San Francisco. As a radiation oncologist, Dr. Coleman is involved in all stages of cancer care, and she treats all types of cancer, including cancer of the breast, prostate, and lung cancer.
Good evening, and thank you for inviting me here today to talk about health disparities in breast cancer. This is a time of great excitement in medicine as new and better approaches to cancer prevention, detection, diagnosis, and treatment are being discovered. However, this progress has not benefited everyone equally, and that's the definition of a healthcare disparity: the adverse differences in health and healthcare between groups. Healthcare disparity refers to the higher burden of illness, injury, disability, or mortality experienced by one group relative to the other. So how big is this problem? One group estimates that eliminating health disparities for racial and ethnic minorities from 2003 to 2006 would have reduced direct medical costs by $230 billion and indirect costs associated with illness and premature death by greater than $1 trillion. Put another way, they estimate that 34% of cancer deaths among all US adults aged 25 to 74 could be prevented if socioeconomic disparities were eliminated. Healthcare disparities can occur across a broad range of dimensions, and these groups are not mutually exclusive, but they can occur because of socioeconomic status, age, geography, language, gender, disability status, sexual identity, as well as race and ethnicity, which is what we're going to talk more about today. Breast cancer is the most common form of cancer affecting women in the United States, occurring in about 15% of all new cancer cases in the US. That means it's going to affect over 275,000 new cases in 2020, with over 42,000 deaths estimated in 2020. Data shows that when you look at the rates of diagnosis and death from breast cancer, looking at the first table, it shows the rates of diagnosis of breast cancer, and it shows that white patients and Black patients are diagnosed at similar rates. However, when we look at the risk of death from breast cancer, which is shown in the second table, Black patients die at a much higher rate than white patients. And in fact, Black patients die at a much higher rate than all other ethnicities. Looking at it in a little more detail, despite the fact that white and Black women are diagnosed at equal rates, Black women are much less likely to be diagnosed with localized disease. This first table shows the distribution in stage of selected cancers in Blacks and whites from 2008 to 2014. When we compare the red bar representing Black women and the gray bar representing white women, we can see that Black women are much less likely to be diagnosed with localized, meaning easily curable, cancers. This can be due to many socioeconomic factors that can lead to advanced stage of diagnosis. Some of those factors include lack of insurance, fear or miseducation about testing, lack of a primary care physician to urge testing, lack of convenience or transportation, or just difficulty navigating the system. Unfortunately, however, stage only tells part of the story. If we look at the second table, which again shows the 5-year relative, this time showing 5-year relative survival rates for breast cancer by race and stage in the United States, we see that Black women, represented by the red bar, compared to white women, represented by the gray bar, have a lower 5-year overall survival at each stage, whether it be regional, localized, distant, or all stages. Black women had a lower 5-year overall survival than white women at each stage of diagnosis. One reason for this could be differences in the type of breast cancer. Breast cancers can express 3 receptors: estrogen, progesterone, and HER2/neu. Most breast cancers express at least one of these receptors, about 65 to 75% of them. But these receptors are not expressed in women with what's called a triple-negative breast cancer. Some treatments are specifically aimed at those receptors, and so those treatments are not available for women with triple-negative breast cancers. In general, triple-negative breast cancers are less responsive to treatment and associated with poorer survival. Triple-negative breast cancers, the subtype with the worst prognosis, are highest among Black women. So this table shows non-Hispanic white women compared to the ratio of triple-negative breast cancers in non-Hispanic Black women. And you can see that the risk is 14.4% for white women versus 27.2% for Black women. Inflammatory breast cancer is a second form of rare aggressive breast cancer that is also more common in Black patients than in white patients. This is an older study, and it divides time periods up into 3-year intervals, but it compares the rate of inflammatory breast cancer in whites with inflammatory breast cancer in Blacks, and you can see that for every time period they looked at, the rate was higher in Black patients than it is in white patients. It's becoming increasingly recognized that these disparities may be due to certain biologic differences. African Americans are more likely to have breast cancer at a younger age and be diagnosed with an aggressive subtype. Emerging evidence suggests differences in tumor microenvironments of breast cancer patients from different ethnic backgrounds. So I don't really want to show the details of this table, but I included it to show that researchers have identified 13 different genes that are expressed in either higher or lower rates in African Americans versus Caucasian breast cancer patients. As treatments become more specialized, this is becoming more and more of a problem. Precision medicine is a method of tailoring treatments for each individual patient's malfunctioning genes. It's a problem if treatments are targeting genes that are more or less common in cancers in African American patients, if those patients are not adequately identified and studied. Most of the work to determine which drugs work, how they work, and how well they work are done on a clinical trial. Clinical trials are research studies conducted with people, designed to answer specific research questions about medical products or procedures. Participants in clinical trials should represent the patients that will use the products. However, racial and ethnic minorities are underrepresented in clinical research, and that is a big problem. This table is from the American Society of Clinical Oncology, which shows African Americans as the percent of US population, around 13.5%, and the percent of participation in cancer clinical trials, which is only about 6%. We know that racial and ethnic differences in drug disposition and response has been identified. This paper showed that race and ethnicity can contribute to inter-individual differences in drug exposure and/or response, which may alter risk benefits in certain populations. Approximately 1/5 of new drugs approved in the past 6 years demonstrated differences in exposure and/or response across racial and ethnic groups. As mentioned before, as therapies become more and more targeted, this is going to become more and more of a problem. Increasing the participation of all minorities in clinical trials is critical for the production of knowledge about new therapies, because having diverse research participants can improve the generalizability of medicine. There are many reasons why African Americans aren't participating in higher numbers. A lot of the times they just aren't asked. They also don't always have the time and resources for the extra visits required for a trial. But a big problem is distrust in the medical system. There's unfortunately been a long history since the times of slavery of Black people not having agency over their own bodies. And this simultaneously has gone hand in hand with a history of medical research being done on people of color without their consent. An example of this is the story of Henrietta Lacks. She helped create one of the most important cell lines in the history of cancer research. Her cells were unique in that they reproduced at a very high rate and could be kept alive long enough to allow more in-depth examination. Until then, cells cultured for laboratory studies survived only a few days at most, which wasn't long enough to perform a variety of different tests on the same sample. Her cells are still being used in medical research today. Neither Henrietta Lacks nor her family gave her physicians permission to harvest her cells. The question of how and whether her race affected her treatment, the lack of obtaining consent, and her relative obscurity continues to be controversial. While many may think that this was a problem from a long time ago, recent lawsuits led to a new NIH policy that required researchers to apply for access to the full genomic sequencing data, when in 2013, the full genomic sequence from the HeLa cells were published without any permission from anyone in her family. Now there's a board that gives permission before her cells can be used, and 2 of her direct descendants are on that board. Another example is the Tuskegee syphilis study. This was a study conducted from 1932 to 1972 by the United States Public Health Service. The men participating were all poor Black sharecroppers who were told that they were receiving free health care from the federal government. The real purpose of the study, however, was to observe the natural history of untreated syphilis. These men were never informed of their diagnosis, the risk of infecting others, or the fact that a treatment was widely accepted as recently as 1945. By the end of the study in 1972, of the initial 399 men, 28 died of syphilis, 100 died of related complications, 40 of their wives had been infected, and 19 had children born with congenital syphilis. Obviously, this provided huge backlash. The New York Times recently published an article entitled, "Did the infamous Tuskegee study cause lasting mistrust of doctors among Blacks?" The result of that paper was pretty much to say, yes, it did, but I don't think it's that simple. I found another paper called More Than Tuskegee, Understanding Mistrust About Research Participation. A quote from that paper said, "Mistrust in the healthcare system has multiple factors. It can come from huge lapses in ethics, like the Tuskegee study, but it can also come from the daily ways in which the system treats some people different than others." I think that more accurately sums up the problem. Data has consistently shown that ethnic diversity of the healthcare workforce is directly linked to health outcomes for people of color. This has been known for some time and isn't new. In 1991, the American medical colleges launched a national campaign to enroll 3,000 underrepresented medical students in medical school by the year 2000. Although the numbers increased since 1991, they did not make that goal. In fact, even now, 20 years later, in 2020, we are nowhere near that goal. This first pie graph shows the percentage of US medical school graduates separated by race and ethnicity. Unfortunately, it projects a little smaller than I would have liked, but if you look at the red arrow, you could see that the percentage of African Americans is 6.2%. The second pie graph shows the percentage of practicing physicians in the United States, also by race and ethnicity. Again, if you look at the red arrow indicating the blue part of the pie graph, that shows that African Americans make up 5.0%. Keeping in mind again that we make up 13.5% of the US population. Lack of workforce diversity is both a cause and an effect of institutional racism. Institutional or structural racism is the distribution of resources, power, and opportunity in our society to the exclusion of people of color. Institutional racism within healthcare impacts healthcare accessibility within minority communities. And unfortunately, it's a form of racism that is embedded as normal practice in our society. People forget that the US healthcare delivery system has historically engaged in systematic segregation and discrimination of patients based on race and ethnicity, the effects of which continue to persist to this day. Neighborhoods which have been segregated for years due to redlining, a process by which banks and other institutions refuse to offer mortgages or offer worse rates to customers in certain neighborhoods based on their racial and ethnic composition. Hospitals and clinics in these minority neighborhoods then experience significant financial constraints and are often under-resourced and improperly staffed. These issues result in inequities in access and quality of healthcare and are major contributors to racial and ethnic health disparities. Another type of racism is individual or interpersonalized racism, which tend to come in two forms. There's explicit bias, which is directly expressed by people who have direct racial preferences and will not be further talked about in this talk today. But a big problem is also implicit bias, which is expressed indirectly. Many times the person who has implicit bias is unaware of the bias, and this can operate subconsciously. An example of that is a doctor who prescribes fewer narcotics to patients of color complaining of pain. Unfortunately, this happens frequently. One study looked at vignettes that were written on paper and read by physicians. Patients who the vignette had a Black patient in the vignette versus had a white patient in the vignette, physicians were much less likely to treat their pain just based on the race of the patient, with all other parts of the vignette being the same. The Journal of Clinical Oncology published a study where Black cancer patients and their physicians, the Journal of Clinical Oncology published a study of Black cancer patients and their physicians and found that providers high in implicit bias were less supportive of and spent less time with their patients than providers low in implicit bias. Black patients picked up on those attitudes, and they viewed high implicit bias physicians as less patient-centered than physicians low in implicit bias. The patients also had more difficulty remembering what their physicians told them, had less confidence in their treatment plans, and thought it would be more difficult to follow recommended treatments. So how do we move forward? There are many pieces to this puzzle, and there are many factors leading to healthcare disparity. All the things we discussed constitute one small piece of a much larger puzzle. We must all work together to try to fit the pieces together to come up with a solution. Fixing just one thing isn't good enough. We will never get the complete picture until we as a country, we as a society, decide that this is a priority and that putting all the pieces together is better for everyone.
Dr. Tiasha Bailey is Executive Director of Komen Chicago. Dr. Bailey joined Komen Chicago in June 2018 with more than 10 years of experience in key leadership positions within the public health sector, including her service as Deputy Commissioner of the Chicago Department of Public Health. At Komen Chicago, Dr. Bailey drives strategy and development to ensure measurable impact upon breast cancer outcomes through research, direct services, advocacy, and public policy.
Good evening. Welcome to my talk titled Breast Cancer Equity in Chicago. It's part of the Northwestern National Breast Cancer Awareness Month kickoff event. My name is Dr. Tiasha Bailey, and I'm the Executive Director of Susan G. Komen Chicago. So before we jump into the presentation, I want to talk a little bit about Komen Chicago and give an overview. Our mission is to save lives by meeting the most critical needs in our communities and investing in breakthrough research so that we can prevent and cure breast cancer. And so that we could one day realize our vision to live in a world without breast cancer. The Chicagoland affiliate was established back in 1997, and our work spans across 5 county areas, which includes Cook, Lake, Will, McHenry, and DuPage County. Since our inception, we have invested $8.5 million in direct services. That includes a range of services such as screening mammographies, navigation support services, survivorship programs, and diagnostic services to those within those communities where the need is the greatest. And we've also invested nearly $6 million in research. And the fascinating thing about Komen is that we have a 360-degree approach to how we address breast cancer, where it is a combination of our investment in research and community grants, our work out in the community and working and mobilizing and empowering our community partners, as well as action. We do a lot of work in heavy lifting and removing structural barriers in the space of policy and advocacy. So here's our agenda. We're gonna jump in and talk about breast cancer disparities, give a little background. I'll talk about our root causes of health inequities. Then we'll do a deeper dive into breast cancer disparities, very specifically here in Chicago, and then move into our Chicago Health Equity Initiative, which is an initiative launched by Komen Chicago, and then we'll close with a call to action. So breast cancer is the most common cancer among women in the United States. 1 in 8 women will hear the words that they have breast cancer. However, what we know is that the rates for getting breast cancer and dying differ greatly across racial and ethnic groups, which lends itself to the health disparities that we see. Often interpreted to mean racial or ethnic disparities. However, disparities can be stratified across a range of factors such as gender, sexual identity, and geographic location, to name a few. And all of these factors play a role in our ability to achieve optimal health. So with respect to disparities, it really means there's a health outcome that is greater or lesser between populations. And at the core of health disparities are structural and social determinant implications. And with respect to structural, this includes policies, our laws, governance, and culture. And our social determinants are more around the physical environment, food security, education, and housing, kind of the things that we need to lead a healthy life. And in my opinion, we shouldn't talk about health disparities without touching on health inequities, because disparities help to describe the problem, and health inequities speak to a larger context of how these differences came to be. And health inequities are described as the systematic differences in the opportunities between groups and lead to different health outcomes. And some of those, that differential access to opportunities for health could include things such as employment and socioeconomic status, to name a couple. This visual, I think, represents kind of a global view of the relationship between structural inequities and the social determinants of health. Braveman et al. Define structural equities as the interpersonal and personal institution and systemic drivers. So the glue that holds this all together, that includes racism, sexism, and classism, to name a few. And that's working in the background. While the social determinants are the terrain to which structural inequities make health inequities a reality. And so when we address both the structural and the social determinants, we're able to lead healthier and more equitable lives in which individuals can live, learn, and work and play in healthy environments, which is what we're looking to achieve. I think the timing for this conversation is critical. We are in the midst of the biggest pandemic that I could honestly say in my lifetime, COVID-19. And COVID-19 has some real implications for breast cancer disparities. What we know about COVID-19 is that there is a disproportionate burden of this disease with respect to cases and deaths among communities of color. And while we have been over the last 10 plus years working to truly close the gap around disparities, we're at a place now where we are imagining that the pandemic will widen the gap. And there's a myriad of factors at work here. Health systems and individuals alike are weighing the benefits of breast cancer care against COVID-19. So at the height of the pandemic, back in the spring, services were interrupted with respect to preventative services. Some treatments were suspended because the risk was so great, and we wanted to ensure that we were not creating a increased exposure to COVID-19. There was also some heightened confusion about when to seek care or when to not engage and overburden the system, which then resulted in delayed care. So we fully suspect that there will be some individuals that have symptoms for breast cancer but have not engaged the system in an environment where they traditionally may have done so pre-COVID. And so we are predicting that we will see more late stage cancer diagnoses down the road. COVID has also caused significant job loss and health insurance coverage loss as a result of that, which creates a significant financial burden upon many individuals. And a JAMA article recently spoke to stress likely playing a role in worsening cancer outcomes. Here you can see, we're talking a little bit, so we're going to shift. We talked a little bit about kind of the background of disparities and what we mean and to our present day. Let's look back and talk about breast cancer disparities in Chicago. So when you look at the chart to the left, it shows the death rate per 100,000 females, and it's longitudinal dating back to 1981, where you can see Black women represent the pink line, white women represent the gray line. And you see that back then, there were virtually no disparities between white and Black women and at the rates that they were dying virtually at the same rate. However, what you see over time is that that gap continues to widen. And by 2007, we had a rate at 62%, where African-American women were dying at a faster rate than white women, although we were getting cancer at a slower rate. To the right, you can see a similar chart, but it really helps to put it in perspective, the Chicago disparity ratio versus the national ratio, as well as New York City, which has a lot of diversity in Black women alike, where you can see New York virtually had no disparities at the time, and Chicago's continued to trend upwards. So just seeing it in a different perspective. And so these graphs were disseminated as part of a report put out by the then titled Metropolitan Chicago Breast Cancer Task Force that found that these disparities existed because there was less access to quality care and to be able for women to access timely care, very specific to mammography, screening mammography, and treatment services. And the question begs we have to ask ourselves is just how did we really get here? How do we look back to say, hey, what is going on that's so special here in Chicago? And what we know is that we have a long-standing history of combined racial and economic segregation that is among the highest in the nation. And that income inequality exacerbates the residential segregation, which we know is a true problem here in Chicago. Dr. Ansel released a book some years ago that highlighted the death gap, where there's a 16 years difference in the life expectancy between West Garfield Park residents and Loop residents, even though these neighborhoods are not that far apart from one another. And some contributing factors that need to be highlighted is that there is limited screening capacity for facilities to be able to meet the demand for screening. There was a shortage in fellowship trained radiologists, as well as inequitable distribution of centers where they weren't necessarily on the south and west sides, the high quality centers. The high volume centers were less likely to serve majority Black or Hispanic populations. At the time, we also had an underfunded state screening program and a fragmented healthcare systems where a lot of our healthcare systems do not talk to one another, which causes and poses some real challenges. So when you look, that's the look back, but thinking about where we are present day. So from 2006 to 2013, there was actually a national decline in breast cancer mortalities due to decreased deaths for white women. So I want to be very clear. due to decreased death for white women. So white women not dying at the same rate, but the overall, there was an overall decline. Chicago experienced an annual reduction during this time of 3.9, and we were the only major metropolitan center city experiencing a decline in breast cancer mortalities at that rate, which puts us in the center of being kind of trailblazers and really closing the mortality disparities here. And we were able to work that rate down from 62% to 39%, which is pretty notable. However, when you break down the existing 39% mortality rate, you'll find by age, you'll find that there's still a death gap that is highest for Black women that are under the age of 40. And there's some reports that state that the rate is as high as 157% higher. And so some contributing factors to the decline over this period of time is the increased local government funding. So there was more access to services and an enhanced capacity. There was an uptick in navigation services with the expansion of those services, as well as the utilization of those services by residents. There was greater parity between screening mammography rates between Black women and white women, meaning Black women and white women were getting mammography screenings at nearly the same rates. We've had some passing of some critical breast health legislation that has helped to remove some structural barriers. And of course, some clinical advancements where we're moving more towards precision medicine and building treatments that are reflective of someone's genomic profile. So what can we do about it? I want to talk a little bit about the work that we're doing at Komen Chicago. Back in 2019, we conducted an environmental scan where we went out and talked to partners to learn from their perspective where they felt that women within their individual systems were falling through the cracks. With the thought that we would be looking more not at individual characteristics of the people that they served, but looking at their systems and their numbers in totality. And what we learned that through our environmental scan, that there was a knowledge gap regarding family history and genetic testing among patients and providers. There, of course, fragmented delivery of care. There was a lack of integrated patient navigation and genetic counseling. The electronic medical record systems were not talking to each other. There was an infrastructure and care coordination barriers in Illinois with respect to payers and our insurance companies. And lastly, there was a lack of awareness about the importance for clinical trials in the African-American community. And I really want to highlight that, the importance of participation among African-American women, and that as advancements are being made in the field, if African-American women are not participating in clinical trial, those advancements and things will not work for our genomic profile. So our participation is really, really critical in order for us to take advantage of those advancements as they become available. So our environmental scan helped us realize that measurable reductions in health inequity can be achieved when access to care is coordinated with and linked to high quality medical services, where we have individual empowerment and community leadership. So kind of a ground up approach. And there's patient-centered care along with navigation, and that whatever improvements you put in place in the primary care setting, that they are truly long-term. And what we have put together is called our Chicago Health Equity Initiative. We took the results from that environmental scan and saw that there was actually something that we could build upon in bringing our partners together. And so what we have is a pioneer initiative addressing mortality disparities across the breast health continuum, where we have partners who sit in the primary care space all the way through to hospital systems and through treatment and survivorship, government as well at the table. And we're focusing on health systems transformation. And together we are working to identify the most impactful points of entry. So when we think about an intervention, where is the best place for us to intervene along the continuum? Is it in the prevention space, or is it more around the diagnostic space? And where we are landing right now is we're looking at expanding and implementing genetic counseling and testing in a primary care setting, so within our FQHC settings, as well as standardizing the practice of navigation services for through diagnostic resolution. So when a woman receives an abnormal screening result, how is that woman moved through the continuum so that we know the outcome of that, the diagnostic result. So our aims are to decrease breast cancer mortality disparities across Chicagoland. We want to reduce the detection to diagnosis interval and really move women through. We also want to increase the number of high-risk women under the age of 40 who receive genetic screening. And this is critical. When you are able to identify your risk for breast cancer, plans and preventative measures can be put in place so that you are being monitored in the event that cancer does show up. There's already a plan in place. Our reach, we're focusing on African-American women, again, under the age of 40. We're looking to serve and track 4,000 women over a 3-year period. And although our efforts are local, we hope to inform national efforts and to have some really sweeping change. Here's our target timeline. Later this year, actually next month, we will be releasing our 3-year implementation plan as part of our 2nd annual Chicago Health Equity Roundtable. We'll move into implementation phase 1 next spring, and then each year we'll move into phase 2 with we will be executing our policy agenda in the spring of 2020, because we know that transforming system is one part of it, but we also have to address the structural barriers that are at play, with the thought that in spring 2023, we will be in implementation phase 3, and we will disseminate a white paper to talk about our findings. So before I end, I want to have a call to action for everyone out there listening this evening, and want people to know that social and structural changes must be made in order to address breast cancer disparities locally in Chicago and across the nation. And we can all play an important role in that. And really knowing that early detection is key. So making sure that you're staying on top of your screening mammograms and following the individualized treatment plan that has been designed for you by your clinician. Making sure you know your risk for breast cancer. If you do not know your risk, please talk to your clinician to get screened, as well as talking to your family to know whether or not there's history of cancer within your family. I ask that everyone advocate for themselves as well as others. For people who don't necessarily have the loud voices, I'm asking that we stand up for each other and really support one another in this time. There's also some critical legislation we're trying to get passed. The very first one is the Metastatic Breast Cancer Access to Care Act to help eliminate barriers to care for our patients living with metastatic, and it waives waiting periods for Social Security, disability insurance, and Medicare benefits. And also we want you to advocate for the Access to Breast Cancer Diagnosis Act, and that'll help increase access to diagnostic breast imaging services. And it helps to increase access to it's medically necessary diagnostic breast imaging by reducing those out-of-pocket costs, which we know are a significant barrier. So I would like to at this time thank you for your time and your attention, and I look forward to questions.
Ryan Johnson is a 2-time breast cancer survivor, originally from Dallas, Texas. Ryan moved to Chicago in July 2018 for her work as an alumni counselor for the Noble Network of Charter Schools. Ryan holds a Master of Education degree from Texas A&M University Commerce and a Master of Business Administration from Florida A&M University. She was on the Speakers Bureau for the Susan G. Komen Foundation in Dallas, and she's done several speaking engagements and fundraising initiatives to advance breast cancer education and awareness.
I wanted to start just by saying thank you to all of the team at Northwestern for having me today. My name is Ryan Johnson. I have lived in Chicago. This is the beginning of my 4th year living here. And I am a 2-time breast cancer survivor. Just celebrated my 40th birthday this past Sunday on the 20th. So I made it. And I am here to just kind of talk about the patient perspective. So my first diagnosis was breast cancer of the right breast, in situ, very early stage, 0 to 1. I'm originally from Dallas, Texas. So in 2008, December, that's where I was living, and that's where I received treatment for the first time. I found my own lump. It was in my armpit, or axilla, which is the medical-ish term. And I went and had it checked out. And the first thing that the person said was, oh yeah, well, you're young, so it's probably nothing, but we'll just, since you're already gonna go in, I was going in to have fibroid surgery, myomectomy. In December, I was scheduled for that surgery, and they were like, well, it's probably nothing, but since you're already going in for surgery, we may as well take it out as well. So I was in the hospital. I apparently bled too much from the myomectomy surgery, so I had to have a transfusion. So while I was in the hospital having the blood transfusion, I was also diagnosed with breast cancer at that time. I went through, I had a lumpectomy, and then I had a mastectomy, right mastectomy, and then I had breast reconstruction. So that process lasted from December of 2018 to about July of 2019. And from then on, I took tamoxifen for about 5.5 years. I didn't have any real complications that time, except that I did discover through that process that I was allergic to morphine. Because I was complaining of pain and nobody was listening to me because they had given me morphine. And so there was a whole ordeal with trying to get people to listen to me that the morphine was not working, and that I was, feeling everything. I felt everything coming out of recovery. So that was kind of a traumatic part of it. And also, at the time, I was told that I could not preserve my eggs because I wasn't married. And that was also traumatic, but I didn't really know much about anything. And I didn't have chemo, so looking back, I didn't need necessarily egg preservation, but I wasn't told that I wasn't going to have egg preservation because I wasn't having chemo. I was told that it was because I wasn't married and the insurance therefore wouldn't cover it. So I don't know what that was about, but that's what I was told. So many years go by. I did lots of celebrations and all the good things. And then I moved here to Chicago in July of 2017 for work. And I was exploring the possibility of having another procedure for fibroids because they were not able to remove all the fibroids the first time. And as you go along, they just continue to grow. So I believe they were pretty big in size once again. So I was exploring the possibility of having another procedure for that. But I had kind of decided to put it off because I just hate surgery for obvious reasons. And so I did. But then when it was time for my mammogram in around February of 2018, February of 2018, I felt like a clump of lumpy tissue, I guess, that I hadn't felt before in the same area on my right side, right along the side of my breast implant. So I went in for my mammogram and I asked them to ultrasound that side, which they did. So long story short, I was diagnosed that second time with a recurrence, same kind of breast cancer, basically same area. But this time, obviously, I was prescribed chemo. Now, I was a patient at Mercy Hospital, then. So I was not a patient at Northwestern for my chemo, but I started to go to Northwestern because of the egg preservation, because they don't do that procedure at Mercy. So I was directed through the patient care people, my care team at Mercy directed me to Northwestern to have my egg removal and freezing procedure. So that was interesting. I hated giving myself injections, and but it was really good because I worked with Kristen Smith, and she was just really amazing, very comforting, very positive, and she was really helpful in getting me grant money to pay for the procedure because it's very expensive and insurance still doesn't cover it, even for cancer patients. So that was great. And I'm still unmarried, but I want kids or might want kids. So I definitely wanted to do the procedure, but it's just one of those things that you it's like a double thing that you're dealing with. You're dealing with cancer and all of that, but then you have this huge question of, what if this takes away my ability to become a mother? Like, is that going to affect in my case, is that going to affect my ability to be married? So I had to deal with a lot of that. Luckily, I was already in therapy, so I just continued to go to therapy and kind of talk about all of that. But, it was very difficult. Just going through it a second time, putting my family through this again. I felt really guilty. And I had a whole lot of guilt, and I still kind of deal with survivor's guilt. But my mother was very supportive both times. She's actually here with me now. And so I got through it. And it's been very helpful to do things like this, where I talk to people about the importance of just paying attention. And so that's kind of like the surface level of my experience with cancer. I didn't finish. So I did have chemo at Mercy, but then since I had done the egg retrieval procedure at Northwestern, I wanted to have the rest of my procedures done at Northwestern. So in January of 2019, once my insurance changed, I switched over to Northwestern, and I had the surgery to remove the breast tissue. And the surgery itself went well, but there was a complication, and I'll talk more about that in a second. And then after the complications and the healing from that, I started radiation at Northwestern, and that was also a really great experience. The staff down there was really wonderful and very kind, and kept me well informed. And so I finished everything in June of 2019. And so I'm, a year and a half or so out. Survivorship, hair's grown back. I mean, I have braids now, but my hair is about shoulder length now, coming from Stark balls. So it's been really good. I wanted to focus more about like the experience of a young woman going through this, and especially someone in my position who's not married. It was just very traumatic. And yes, you do have lots of people that always kind of point out your age and go, oh, they give you pity, or they just talk about how young you are. And so like, you shouldn't be going through this. And it's like, well, no, I shouldn't be going through this, but I am. I was 28 when I was first diagnosed, and I was 38 the second time. So both of these times I went through before I even hit 40. I just hit 40. And so not only, again, do you have to deal with, the issues of your mortality, but then also your fertility. And so it's just very important to have support. I went to therapy, and that was helpful for me. I tried to do support groups, but the support groups that I kept getting directed to were really white dominant. Like, it was a lot of white women in there, and a lot of white married women in there. And I just didn't really feel comfortable. I didn't feel like I could relate. They were just talking about things that either I hadn't experienced yet, so I had no idea what they were talking about, or B, just life is just really different for them. And I just didn't feel comfortable in that space. And so I do feel like there should be more spaces for Black women and young Black women who are battling cancer and learning how to survive. just to make it more open to talk with. But therapy, one-on-one therapy helped me quite a bit. And I also wanted to say to healthcare professionals, as it relates to the health disparities and how Black women die pretty much from everything more often than everybody else. I would say in my case, at every hospital I've ever gone to, every procedure I've ever had, at one time in that procedure or another, I've always had to deal with the feelings of not being listened to at Northwestern and all the other places, honestly. Feeling like not being listened to, not being heard, not being believed. And I think that those things are at the root of why Black women die, because we are invisible to people, honestly, unless we are loud and boisterous and angry and all those stereotypes that you hear. People don't listen to us and they don't believe us. And because of all the things we know and have heard about how healthcare professionals feel like our pain tolerance is different or non-existent, people don't listen. And it's not, and it's across the board. It's doctors, it's nurses, it's techs, it's everybody. And so I would say to other women who are watching this, you have to know your body more than anybody, more than any doctor that you see. You have to explore yourself, know what's normal for you and what's not. And when you get pushback, when you are talking to your healthcare professionals about what you're experiencing and they attempt to be dismissive, you have to be insistent. And even if that means that you have to be that angry Black woman that people look at you and think that you are anyway, you just have to be that, because that's what I had to do. And that's what has saved my life, and that's what has kept me here, because I could have been out of here and just having a much worse time if I had allowed myself to be dismissed by the healthcare professionals that were attempting to do that. And so, like I said, it's pervasive. And I think definitely on the professional, healthcare professional side, definitely all of the research and all those things need to be done to address this from their end. But just speaking from the perspective of a patient, you have to know your body and you have to be very insistent, very assertive, and not take no for an answer, and make people show you things, make people document, make people run tests, even when they don't want to, and even when they tell you that, oh, it's just this or it's just that. You say, no, I know my body and something's not right, and I'm not going to leave until I get what I'm asking for. And you have to call it out. And that's what has made the difference in my care, is me being my own best advocate and me being my fiercest advocate, and the people that I brought with me also having the courage to do that on my behalf when I couldn't speak for myself. So I think those are the most important things. I don't know where I am with time. I hope I haven't gone over, but thank you again for having me. Appreciate it. And just let's beat this thing, everybody.
So I want to thank everyone who talked tonight, and particularly Ryan, who gave us a very compelling story of her journey through her breast cancer and the one that continues, and also to Tiasha and Joy. So we have a few questions, and before we even get into the ones we do have, I want to emphasize again that if you want to ask a question, go to the Q&A function, not the chat, but the Q&A, and put your question there, and we'll try to address it to the panelists. So there were several questions having to do, and obviously the first two speakers really covered to a large degree what is perceived as some of the systemic problems that exist that may account for the disparities, as well as the biologic factors that may play into this. And I guess one of the questions that came from a few people's rephrased on my part is, what do you think the one thing we can do as a community who takes care of patients, or as cancer centers, can do that's going to have the greatest impact on changing those disparities that exist? We've each of you have talked about individual things that account for it, but what do you think could make a meaningful difference? And I'll probably start with you, Tiasha.
I think that's a great question, and thinking about organizations that they really need to turn the mirrors on to themselves, which I believe that the Chicago Health Equity Initiative is doing, taking a hard look at systems and the role that they play in driving disparities. I think organizations have to be honest with themselves about where their patients are falling through the cracks, where, are they, looking at the diversity or lack thereof within their clinical care teams, because that's important. Representation is important across for that, as well as within leadership and their administration, making sure that their policies are equitable and that their policies are not driving the disparities. So it's really about organizations being intentional and critical of the role that they play, and then putting together a plan to address that.
Joy, any thoughts?
Yes, I think that's an excellent question. And I actually tried to put that together when I was putting my talk. And I unfortunately don't think there's only one thing we can do. I think it's such a large multifocal problem that it requires a multifocal solution. But I think within organizations, I think the importance is just having leadership that commits to change and acknowledges that this is a problem. Once they've done that, I think that's taking the biggest step. From there, I think appointing a diversity officer who's really going to look at everything and hold the institution accountable is extremely important. The statistics are there and the numbers are there. So we know what the problem is. We just need to work on it. From there, I think causing change within individual people is important. I think it's important to do bias training so that physicians can really look at their own implicit biases and maybe make changes that they don't even know need to be made, so that we can really affect individual direct patient lives. So I think those are just a few examples of things that organizations can do just inwardly within themselves to try to help with some of these problems.
Yeah, and I would say the point of diversity officers in institution is a new trend. I think, of course, if you're going to have such people designated, they have to be empowered and not buried somewhere in the labyrinth of the structure in the org chart. They have to be answering probably to the leaders of the organization, not somewhere buried under, an associate vice president of who knows what, just as an editorial.
No, absolutely. I couldn't agree more. And I think that that's why I started by saying that the institution has to really be committed to change. And it really has to, unfortunately, come from the top. And they have to really be committed to, as you said, empowering that person to make change in the organization.
Right. And I know that Ryan's experience has really highlighted this notion of implicit bias and bias training. And, institutions vary in how much they pay attention to that. I know that at Northwestern, there's a program through a grant that now everyone has to do it from every department, at least downtown. But do you think that potentially could have some impact on the kind of experience that Ryan had as she went through her journey?
So I absolutely think it could. And I think hearing her story was wonderful, because I felt like she echoed many things that I said in my talk, and she hadn't heard my talk before, but she was able to put a very human and personal face on some of the statistics that I gave. When I was talking about how, doctors reading a vignette don't give enough pain medications to Black patients in a vignette, but then she was saying how as a person she went through this and wasn't getting enough pain medication and didn't have her pain needs addressed. I really felt for that. And I really do think that we can make change and people can make change. And I think that doing education things like this are really, really helpful, and hearing actual patient experiences and stories. Hopefully people can listen to that and internalize that and grow from that.
Yeah. So I want to come back to maybe Ryan and Tiasha, because one of the thoughts I had, and I think it's peripheral to or tangential to some of the questions that have been asked, but it's still thematically in keeping. And that is, we're starting to see around Chicago, places like Mercy, Westlake, a variety of safety net hospitals, community hospitals closing. And it's often been our experience, right or wrong, or our impression, I should say, that you know, African American folks in the community oftentimes feel more comfortable at such hospitals than coming to the big mega center. So how do you help direct us as people in those centers feel like we're being more receptive, or make a receptive place for these people to come to, as the places they feel most comfortable seem to be closing with much too much frequency these days? And I'll just toss it to Ryan for her thoughts, and then maybe to Tiasha.
I think that a big reason why patients may feel more comfortable at those neighborhood hospitals is because a lot of the staff and healthcare professionals reflect the community. There are, you know, a lot more people of color, not just the doctors, but, you know, the nurses and the patient care techs, the people that interact most often with patients are people that are more reflective of those communities. And so they have, I think, an innate cultural understanding of how to relate to patients in those that they see, that may be harder for a Northwestern, which is downtown in the heart of the loop, where a lot of the people who live in these communities hardly ever have a reason to go. So they're not seeing themselves reflected in the staff there. So that just makes a difference. And I think even, and I know it's a good thing that that the healthcare system at Northwestern is so comprehensive, because that means that you can go there and just it's kind of like a one-stop shop, which is great. But that, I think that's also it can also kind of be physically intimidating just to see all these buildings. It's really intimidating for someone who's like, you know, vulnerable and trying to navigate. And I would say, like, with my experience when I started at Mercy, that I didn't have when I started at Northwestern, for example, was a patient care tech. There was someone that was assigned to me that helped me understand who all of my clinicians and my doctors and all my care team would be, and they kind of helped usher me to those different places, and that made it a lot less intimidating. And that was something that I do think was missing from Northwestern, was just that one person that you could go to and ask a bunch of questions and get quick answers, and that would be that one person that kind of could shoot through some of the red tape, if you will.
Okay, thanks. Tiasha?
Yeah, she actually, Ryan touched on the key points. I mean, the proximity is a huge barrier, but the diversity for sure. And I was thinking in my mind, lay navigators and just the feel of those community hospitals where it feels more patient-centered, right? When they have more of a handle of some of the challenges and barriers that get in the way of patients accessing those services, and then they create those supports around patients. And I think that that's something that the larger systems need to really look internally to see how they can go out and have a presence in communities and get a sense of those barriers, but then develop some social supports to really help people navigate and make sure that they don't fall through the cracks.
Great. Joy, you were talking over the course of your comments about the difference in biology between breast cancer that develops in African-American women and other populations. And I guess one of the questions is, you know, this doesn't obviously apply, you know, Breast Cancer Awareness Month is often early stage breast cancer, you know, early detection, but the reality is a lot of patients develop metastatic disease. And one of the ways that we gain greater understanding of, you know, how we better treat the disease, investigate new things, is by putting patients on clinical trials. And that, as you pointed out, because of the historical context of Tuskegee and so many other things, has been a real barrier, particularly to underrepresented populations in clinical trials. So how do we overcome that?
So the good news is that a lot of people are now looking at that. One of the graphics I presented in the talk was from ASCO, and they were going in front of Congress, really presenting this, trying to get national initiatives to try to address this problem. I think the biggest thing is that we need to have a network to let patients know that clinical trials are available to them and let them know how important they are. We need to address some of the barriers to getting patients on clinical trials. For example, if they can't get to academic institutions because they're harder to, we have to be able to take the trials to them, to these smaller community hospitals and form partnerships and things. We need to be able to support patients so that if they require extra visits for lab draws and whatnot, that could mean extra time off of work that they can't do. And then we really need to take the time to explain to patients the purpose of it and what it's for. You know, many times the patients just don't quite understand what the research is for, and that they don't think the research is going to benefit them, and they're concerned that they're going to be giving their body to just benefit somebody else, and they don't see how it directly affects them. So I think that there are a lot of ways that we can try to tackle that problem, both on a larger scale and on a more individual scale.
And it just as an editorial, that is, you know, one of the mandates of big centers is to not only enhance clinical trial enrollment globally, meaning across all populations, but particularly among underrepresented populations. And that's one of the demands that the National Cancer Institute has. So it's on all of us to try and reach a solution that'll improve those numbers. There was a question as well about, and I guess we could start with Tiasha and then whoever wants to comment. You know, there are a lot of patients that simply don't have access to some of the big centers because of the perception, I have no money, I have no insurance. How do I optimize, you know, my chances, my cancer care when I feel like I've got nothing?
Yeah, and I think that's kind of the role of Susan G. Komen, if you will, to kind of be that conduit and connecting people. We get calls all the time of wanting people saying, hey, this is my situation, I'm uninsured, or I just lost my job and I think I may have a lump. And so we serve as a convener to be able to ask some of those critical questions, to learn where they live and learn more about them and what they believe their needs are. And then conduct that warm handoff, because that's the important piece. A lot of times people are like, well, I think I know about this particular hospital, but I don't even know how to get in or who to call or what to do. And so I think that's the role of organizations like us, to really stand in the gap, to connect people to resources in real time, and then checking in with them to just make sure that they got what they needed.
Okay, and Joy, let me throw this to you. There was a question I almost forgot about. You know, several of you have been talking about the differences between populations in terms of accessing things like mammograms, and as a result, downstream, there's a difference in outcome as well as biology. So it's not just access, it's a variety of things. But do you find, because you care for patients with other malignancies as well, that those same factors apply, whether it's lung cancer, colorectal cancer, other malignancies?
Yes, unfortunately, that's absolutely the case. This talk was focusing on breast cancer, but there are many, many cancers that are either diagnosed more prevalently in Black Americans, or Black Americans die at higher rates, such as prostate cancer, stage for stage, than Caucasian patients. So unfortunately, that's a problem in a lot of different cancers, and a lot of different cancers, like you said, that have screening tests, like lung cancer and rectal cancer and prostate cancer. Unfortunately, we still aren't doing as well as majority patients.
Okay. And Tiasha, there's a question sort of generally about mammograms for when, and anybody's welcome to comment on this, in a patient that has a family history of breast cancer, the recommendations in a young woman, particularly African-American woman who's young, who wanted to get a mammogram, but because of her age, they said, no, you shouldn't get a mammogram. So I realize that's sketchy details, but nonetheless, how would you counsel or at least talk to somebody about that? Or what recommendations would you give regarding when it's appropriate to get a mammogram? And are there any other considerations, particularly in a patient that may have some sort of family history and is also African-American?
Yeah, I mean, I know the guidelines speak to women generally that are considered low risk for breast cancer to start mammograms at the age of 40. But I mean, Ryan's story is a great example of why you can't necessarily follow that, and that you really have to know your body and know kind of what normal looks like for you. And if you are, if you have a family history of breast cancer, talking to your clinician about that, requesting some genetic screening just to see whether or not you have one of the genes that put you at greater risk for breast cancer, and then advocating for yourself. I mean, I've had some individuals who have had doctors who've had that firm, you're not 40, you're not at risk, and the answer is no, and it just wasn't a fit. And in those situations, we've told women, hey, maybe that doc is probably not the best fit for you, maybe going somewhere else. If you have a compelling case behind why you believe you need a mammogram, and so that you want a clinician that'll listen to you, and where it's more of a partnership to get you the care that you need and you deserve. And I'd be interested to hear what Dr. Coleman would say about that as well.
I would agree. I really think you hit the nail on the head, that we really need to make sure that people have primary care physicians that they feel a partnership with. When Ryan was speaking, she said something about how she really felt very alone when she was going through it. And she felt like she had the support of her friends and family, but it didn't sound like from her talk that she really had a physician advocate that she really felt like was on her side. And I think that's extremely important, because navigating the medical system at this point is extremely, extremely difficult. And it's something that's very hard to do by yourself. And I think that if your primary care physician and you aren't on the same page, then you're absolutely right. Then that's the time to find a new primary care physician. And I think that that's so important. And it's so important to find someone that you feel like understands you and knows where you're coming from and listens to your concerns and takes them seriously.
Great. And I would just add too that, there are circumstances where it's perfectly appropriate, where you don't fit the exact guidelines to be getting imaging done, even if you're younger. But I think it also takes some time that the clinician has to spend with the patient to explain what tests, the pluses and minuses of doing certain tests at certain ages may be. False positives, false negatives, more biopsies, all of that takes time. So I think, as everybody pointed out, there has to be a willingness to at least have the dialogue, so somebody doesn't feel like Ryan did on many occasions, where her concerns were sort of blown off. So I think that's part of the equation too. There was a question at the beginning that really, I think I'll ask Ryan and then whoever else wants to comment. And it really focused on the fact that, we often think about supporting the patient. Obviously, that's the focus of everyone's attention when there's a diagnosis or a concern, but there's a support group that surrounds the patient as well. Family members, other people that are involved in the care and support of the patient. And the question really focused on what are some of the things systemically, you went through this, so that you think or perceive might have been better if there was some attention paid to the other caregivers in your life. In other words, like your mom, as you said, was very supportive of you. There may have been stressors on her as she made accommodations to help you.
Yeah, definitely. My mother pretty much stopped working to take care of me, and that ends up being, especially in the early days of if you have surgeries or chemo, because you have to go so much to the doctor, and then you just kind of need around the clock care right after procedures happen. So yeah, she pretty much stopped working really both times to take care of me. And so I know that was a privilege of mine, that I had a family member who was able to do that. So I do think and just through my volunteerism with Komen and American Cancer Society, I know that there are in cities organizations, and I know that Komen and others partner with smaller organizations to provide that type of service to people, but I know that it's not as widely known that that type of help is out there. And I think that stuff like that is also some of those things that keep people from presenting earlier and trying to get screened to see if there is something wrong. Like, they don't want to know if there's something wrong if they feel like they are not able to do anything about it. And if they're not going to have anybody to take care of them, they don't want to burden their family and friends, so they don't even bring it up. And so to know that if you don't have a caretaker, that there are organizations that can help find you a caretaker, can help find you rides, can help you get the testing and the treatment that you need. It can help pay your bills if you're not able to work. Knowing that stuff on the front end, I think, is a really big part of what helps people feel more comfortable, but it's also definitely something that keeps you from speaking out earlier, is to kind of already think that they're not going to have that.
Okay, Tiasha?
No, there are a lot of co-survivor programs and services out there. To your point, we focus a lot on the patient, and in order to really keep that patient healthy, it's about that network and people around them. And so taking care of them and their mental health and supporting them, and whether or not they have some financial challenges as well, is so important. And just keeping everyone's needs met is crucial.
Great. Well, guys, it's hard to believe, but we are at time. And I want to really thank Ryan, Joy, and Tiasha as the panelists who really provided the meat for this discussion. And importantly, I want to thank everybody who is anonymously out there, some of whom submitted questions. I think it generated a rich discussion. We don't want this to be a one-off. We'll do it again. And until we have a better fix on the problems that you all discuss, I think it's worth discussing frequently. So thank you all. Have a good night. Stay safe and stay well.